In the name of Allah, the most beneficent and the most merciful. Assalamu alaikum, students. So the topic of our today's lecture is cardiac cycle. Today we will be discussing that what is cardiac cycle, what is the duration of cardiac cycle, what are the mechanical events associated with the cardiac cycle. Will have a bit overview of the ECG, and then we will be discussing the work output of cardiac cycle and also the stroke volume and all these kind of connected things. Okay, so let's start with the introduction of cardiac cycle. Cardiac cycle, to be really very simple, it is the sequence of events which is occurring from one heartbeat to the beginning of next. Okay, so it is the sequence of events. Now, what sort of events are taking place in the cardiac cycle? These are the electrical, mechanical, valvular, and volumetric changes that are occurring from the beginning of one heartbeat to the beginning of next. And basically, these changes are causing the heartbeat. These changes are causing the heart to beat or to pump blood. Okay, so to understand this thing, we know that there is a specialized conductive system in our heart which will generate electrical impulses. For example, we say that as a node generates electrical impulses, the electrical change will be followed by what? Mechanical action. Where, for example, SA node will generate the electrical impulse and it will act on the atria. The atria will contract, which is a mechanical event, and then through this mechanical event, the AV valves will open and there will be a valvular event, i.e., the opening of the AV valves, and then there will be blood from the atria to the ventricles due to atrial contractions. When the atrial contraction occurs, the volumetric changes also occur because when the atria will contract, the volume will be what? The volume will be decreased. Okay, so it is a sequence of electrical, mechanical, valvular, and volumetric changes occurring from the beginning of one heartbeat to the beginning of the next. Okay, now coming towards the details of the cardiac cycle. Cardiac cycle is initiated by the pacemaker of our heart, which is the SA node. SA node, or the sinoatrial node, which is the pacemaker of heart. It is located in the superior lateral wall of the right atrium. So we know that the superior lateral wall of the right atrium contains SA node, which is the pacemaker of the heart. They note the electrical impulses have to travel to the AV bundle ventricles. Because the ventricles and the atria are separated by a fibrous tissue, the impulses generated in the atria cannot directly innervate the ventricles. So the impulses travel from the AV node, and then there will be, of course, the contraction of ventricles. So due to this traveling, there is a delay of 0.1 seconds. That is why the atria will act as a primer pump and will contract ahead of ventricles. Now, coming towards the duration of the cardiac cycle. The duration of cardiac cycle is calculated by taking the reciprocal of the heartbeat. Now, heartbeat equals number of beats per minute. Heart rate equals number of beats per minute. So the duration is inversely proportional or the reciprocal of the heart rate. So the duration becomes minute per number of beats. Minute per number of beats. So we have 72 beats approximately. The normal range is 70 to 75. But to be very exact, which is almost not possible, 1 over 72. We will take 1 over 72. There are approximately 72 number of beats, but the range is 70 to 100. Okay, which may differ from book to book. Okay, so 1 over 72 gives us the duration of cardiac cycle 0.8 seconds. What is it? 0.8 seconds. So the duration is inversely proportional to heart rate. What does it mean? It means that if the heart rate will increase, the duration will be decreased. If the heart rate increases, i.e., when there is tachycardia, the duration of contraction will be decreased. But when the heart rate is decreased, the duration of contraction will what? It will increase. Okay, when the heart rate increases or there is tachycardia, the duration of contraction decreases, particularly for the diastole. Particularly for what? Particularly for the relaxation period of the heart, which is known as diastole. The mechanical events that are taking place in a cardiac cycle. There will be ventricular filling period, isovolumic contraction period, ventricular ejection period, isovolumic relaxation period. First of all, we will take a look on this diagram so our understanding will get quite better. Okay, so what is it? It is the superior vena cava and it is the inferior vena cava. The superior and inferior vena cava will pump blood into the right atrium of our heart. They will pump blood into the right atrium of our heart, and these right atria will pump blood, and they will in turn pump blood to the pulmonary artery, which will go to the lungs, and then the lungs will oxygenate the blood, and then we are going to have oxygenated blood to the left atrium, and then the left atrium will pump blood to the left ventricle. Then the left ventricle will get contracted and will pump blood into the aorta or into the systemic circulation taking place in this whole pumping process. First will be the ventricular filling period. Now, when will be the ventricles filled? When the atria will contract, the ventricles will be filled, of course. But the ventricular filling is not only due to atrial contraction or the atrial systole. We will be discussing it shortly. Then comes the isovolumic contraction period, ventricular ejection period, isovolumic relaxation period. Now let's see what are these phases. So first one is the ventricular filling period. So what happens is that there will be blood, the atria will be filled with blood. Okay, so the pressure in the atria will open the AV valves or the atrioventricular valves and the tricuspid valves, and the blood will move from the atria to ventricles. About 80% of the blood moves from atria to ventricles without the contraction of atria. Ventricular filling period is actually divided into three parts. But when the ventricular diastole corresponds to atrial systole. First of all, there will be rapid filling phase. There will be increased blood pressure, which will open AV valves, and then there will be, of course, influx of blood into the ventricles. Then there will be slow filling phase due to sustained and there will be sustained low pressure of blood, which is known as diastasis. Slow filling phase, rapid filling phase followed by slow filling phase, and then the filling is completed by what? It is completed by atrial systole, which will contribute about 20% of the blood to the ventricles. It now the blood, and first of all there will be 80% blood from without the atrial contraction, and then about 20% of the blood will come through atrial systole. So there will be approximately 130 milliliters of blood in the ventricles when they are fully filled, or when they have the diastolic, when they are in the end of diastole. The diastole refers to the relaxation period, while the systole refers to the what? It refers to the contraction period. Now coming towards the atrial systole, as I have already told you that the 80% of the blood in the ventricles is pumped without the atrial systole just due to the pressure. Then there will be atrial systole, which will be responsible for 20% of the filling of the blood in the ventricles. It is due to the impulse generated by SA node, which will travel through the atria, will depolarize the atria. First, the right atrium will contract. We have a very slight difference between the contraction of right atrium and the left atrium. So, as the SA node is located in the right atrium, first the right atrium will contract, which will give this half of the P wave, and on the ECG, and then there have the left atrium, which will give this half of the P wave. Okay, so there will be atrial depolarization and the atria will contract, and when the atria will contract, they will pump their blood into the ventricles, and the ventricle will achieve their end diastolic volume, which is about 130 milliliter. Okay, for the left ventricle. Now this is the P wave, or the first wave of the ECG, which is due to atrial systole. Now I have already told you that this half is due to the right atrium and this half is due to the left atrium. Now if the right atrium enlarges, so we will get a sawtooth like wave on the ECG. After the enlargement of right atrium, we will get what? A sawtooth like wave on the ECG. Now coming towards the other phase, or the next phase, which is the isovolumic contraction of the ventricles. There will be no change in the volume. The word itself says that there will be no change in volume, but there will be contraction. Now what will happen? So that we will say it contraction, there will be increase in pressure, due to which we will be saying that it's isovolumic contraction. So what happens is the atria repolarize and relax. The atria will be repolarized and will be relaxed, i.e. there will be atrial diastole, there will be atrial diastole, and the ventricles will be depolarized. When the ventricles will be depolarized to the AV nodes, the ventricles will be depolarized after the atria, approximately 0.1 second after the atria. The ventricles will depolarize and they will because the contraction should be isovolumic, so the valves, both the valves will be closed, both the atrioventricular valves and the valve and the pulmonary valve. The atrioventricular valves and the aortic and pulmonary valves will get closed, and we will obtain QRS complex on the. ECG. We will get QRS complex on the ECG. So when the isovolumic contraction occurs, I've already told you that there will be increase in the pressure. This increase in the pressure causes closure of AV valves. It causes the closure of AV valves, and thus there will be isovolumic contraction because the aortic valve is already closed and the AV valve will also be closed. So there will be isovolumic contraction, i.e., the volume of the ventricles won't change in this phase. And due to the closure of AV valves, there will be a sound will be generated known as S1 sound, where AV valve closure or the tricuspid valve closure or the mitral valve closure. Okay, now coming towards the ventricular ejection. First, there will be isovolumic contraction, then there will be ventricular ejection. Now, in ventricular ejection, there will be rising pressure. The rising pressure will exert force on the semilunar valves and the aortic valve and the semilunar or the pulmonary valves, and the pressure will open the valves. The pressure will do what? It will open the valves and there will be injection of blood from the ventricles. Now, how much pressure is required to for the left ventricle, i.e., for the aortic valve, there should be pressure of greater than 80 mmHg or 80 millimeter of mercury, and for right atrium or the pulmonary valve, there should be pressure greater than 8 mmHg, which will be required to open the pulmonary valve. Okay, ventricular systole, of course, the ventricles will contract and the aorta will be filled with blood. The ventricular ejection period. One will be the rapid ejection, then will be the slow ejection, and then will be the ventricular systole. About 70% of the blood is pumped into the aorta through the rapid filling phase, and then 2/3 of the blood is pumped through the rest of two phases. Now coming towards the stroke volume. Now the amount of blood ejected by the ventricles into the aorta is termed as what? It is termed as stroke volume of the ventricles. It is termed as what? It is termed as the stroke volume of the ventricles, and it is about 70 milliliter of blood. It is what? It is 70 milliliter of blood. How much blood there was in the ventricles at the end of the diastole of ventricles? Very good. There was 130 ml blood. So 60 ml of blood is not going to be pumped into the aorta from the ventricles, which will be called as end systolic volume, i.e., it is the volume of the blood present even after the ventricles have undergone systole. Okay, it's the stroke volume and the efficacy of heart. Stroke volume and heart rate are really important in measuring the efficacy of the heart. If the stroke volume is okay, of course the heart rate is also okay. Of course, the heart is working well because it is able to the strength of the heart is enough to eject normal quantities of blood. Okay, the stroke volume is also a diagnostic tool, and it is measured by the stroke volume is measured by ECG and the Doppler ultrasound. Stroke volume is determined by what? It is determined by ECG and Doppler ultrasound, and it is of prognostic important for the patients of heart attack. Person has undergone heart attack, and then after that he or she is suffering from lesser stroke volume, so he or she is at a higher risk of death and other complications. Okay, if the stroke volume is not normal even after a person has undergone heart attack, so it will be of prognostic importance. If the stroke volume is okay, the person is going well, but if the stroke volume isn't okay, so it will indicate that the person is suffering from other types of complications. Okay, stroke volume is the amount of blood ejected per contraction by the left ventricle. The ratio of stroke volume and the end diastolic volume gives us the ejection fraction, i.e., it tells us that how much fraction of blood is being ejected with every contraction. So the stroke volume divided by the end diastolic volume gives us what? Gives us ejection fraction, and the ejection fraction for normal heart should be 54% or approximately 60%, and a person who is having vigorous exercise should have an ejection fraction of 90%, while a person with diseased heart has ejection. So that's how the stroke volume is important in determining the health of heart of a person. Now coming towards the isovolumic relaxation. After the ventricular systole, there is isovolumic relaxation of ventricles. There will be depolarization of ventricles, which will be manifested as the T wave or the third wave of the ECG. Blood will flow from the ventricle to the aorta. When the blood flows from ventricle to the aorta, there will be closure of semilunar valves. There will be closure of semilunar valves, due to which a sound will be heard, which is known as S2 sound. Which is known as what? Which is known as S2 sound. And this repolarization gives us T wave. Changes may be due to electrolyte changes. If there is a change in electrolytes, as we have seen in P wave, that there is enlargement of the right atrium, there will be sawtooth like wave. So this T wave is electrolyte is managed by electrolyte, is disturbed by electrolyte changes, mainly potassium changes. Mainly by what? Mainly by potassium changes. Towards the work output of our heart, there are two kinds of work. We will be discussing two kinds of work output: the stroke work output and the minute work output. The stroke work output is for one contraction, while the minute work output is for the whole minute. Okay, so the minute work output will be what? Stroke work output into heart rate. Heart rate is what? Beats per minute. So minute work out is calculated by stroke work output into the heart rate. The stroke work output is the amount of energy that the heart converts to work during each heartbeat while pumping blood into the arteries. So of course, there will be blood in atria. The atria will undergo contraction. Then the valves will open. The valves will be opened. Of course, there will be blood in atria, which will move from atria to the ventricles by opening the valves. Then the atria will undergo contraction. After that, the ventricles will undergo contraction, and there will be a great many changes to pump blood from the ventricles to finally to the arteries. So there is a lot of work going on in the heart. That work that causes one stroke volume to be ejected is known as stroke work output. Well, if we multiply the stroke work output into heart rate, we will get the minute work output. Okay, so that's all for today. I hope you find this video useful. Stay tuned and subscribe to my channel.